very much. Yeah, no, it was a pleasure. It was a pleasure to get us through it.
Thanks, Jill.
Great. Okay, colleagues, thank you. We'll move on then. Chair's report. You have it in front of you. There is just one item I'd like to bring to your attention, which is item 8. As you know, the board in our constitution has a deputy chair, previously held by Elizabeth Sedgley, which is very much an ambassadorial role. Really, if I was on leave or if I was double booked, then the deputy chair would step in. But in line with the legislation of the 2022 Act and the fact that we're now legally obliged to participate in partnerships and collaboration across Lancashire and South Cumbria, the role of the chair and the workload of the chair has increased incrementally to include partnership work and engagement with the ICB, etc. And talking with Paul and going through the workload and speaking to the NEDs, I'd like to explore further and seek your permission to explore further the principle of having 2 deputy chairs. One deputy chair would help me on the internal work inside the trust. The other deputy chair would support me in the external work that we do across the patch with partnership. And if I get run over by a bus or suddenly have to leave or whatever, we're saying that one of the deputies would then step up as the interim chair and suggesting that Deputy A would take January to June and Deputy B would take July to December. So there will always be cover here. We'd like to explore that further before we come back to the board and the Council of Governors, because the Constitution is quite clear that the Council of Governors confirm the decision following a board discussion. Colleagues, happy to explore that further. Paul, anything you wish to add as company secretary?
No, summarises our discussions, Mike.
Okay, thank you. Anything else on the chair's report that you wish to bring to our attention? No, thank you. Then we note my report and note the with thanks the agreement that we can explore that issue further and come back in December. We'll move on then to the Chief Exec's report, item 1, 2, 4. Aaron, please.
Thanks, Chair. So as I normally do in my Chief Exec report, colleagues, I'll talk to 3 areas: national, local, and then trust specific. I'll keep it to time, Chair. So from a national perspective, there is still a lot of focus from NHS England in particular on 2 key areas: preparations for winter and our urgent care fragility. And colleagues might have seen again in the headlines over the weekend and early this week some systems declaring significant pressures. Our own response we talked about in drafting a board workshop form last month, and Scott McLean, the Chief Operating Officer, will be presenting our resilience plans later on today. The other area is our financial position in the NHS. Lots of systems again declaring significant financial distress and difficulty in keeping to plan and looking at their forecast position. Again, we've done some good work as a board up to month 6 to keep oversight of our plan and agree our own delivery plans, not just for this year, but under the strategic financial improvement plan that Chris has led. We know where we're heading. But again, we are not an island and protected from that pressure. And again, Chris is going to lead the board through a session this afternoon on financial position. So from a national perspective, we're connected into those key programmes of work as a trust. The last point I mentioned nationally is I received a letter, as some other colleagues, I think it was Monday, that the BMA intend to ballot their members next week on further industrial action. I've said a number of times that our teams have become very, very good at managing through periods of industrial action, but it is not business as usual. It comes with risk, it impacts on patients, it impacts on colleagues' health and well-being. So we will need again careful consideration of any escalative industrial action. Just to let colleagues know, of course, that was received earlier this week. From a system perspective, one note of housekeeping: Lancashire Teaching Hospitals colleagues will be aware that they have gone out to advert recently for their new chief executive following the departure of Kevin McGee. Chris Aycock, our finance director and deputy chief executive, participated in the stakeholder groups for that appointment, and I'm delighted to announce we won't renounce it, LTH have done that, but to reflect that Silas Nichols, who's currently the Chief Executive of Wrightington London League Trust, will be joining the system as LTH CEO. Look forward to working with Silas as part of the providing collaborative and due course chair. From a trust perspective, two pieces of news that I'll use this platform to update on. But first of all, I just wanted a bit of reflection. Colleagues will have seen in the media over the last month or two, actually, quite a lot of statements, discussion, kind of media attention around matters of LGBTQ+, trans colleagues and patients, and more recently, the equality, diversity and inclusion agenda. With lots of discussions around the relative approach from the NHS, the commitment to those agendas and the investment required to service those agendas appropriately for both patients and colleagues. I just wanted to say here again, our board's commitment to particularly the EDI agenda is unequivocal. We've made this position clear for as long as I've been Chief Executive for half a decade, and have done some very, very good work with our networks, with our colleagues, with our partners to include all members of our teams and patients in their lived experience and making improvements where we need to. Particularly for EDI, it is a skilled and professional area that requires good quality professional input, challenge and reflection for us to make sure that we're taking forward these programmes of work appropriately. So of course we will continue to sponsor that. I'm aware that we've got teams to recruit to now under Ali's leadership, which we'll continue to do. And of course that includes a right and reasonable challenge on value for money and whether we can still achieve our financial and performance targets alongside that. So I just wanted to make that point here, Chair, just to make sure it's clear that this board is still sponsoring and promoting improvements in these areas under our Great Place to Be cared for, a Great Place to Work initiative. Other areas then for us, delighted to announce here at Public Board that on the 23rd of October, we were formally recognised as exiting the National Recovery Support Programme, moving from the lowest strategic oversight framework rating of 4 to a soft rating of 3. That's now been ratified in writing to myself and the Chair. Colleagues again will know my approach to receiving that news is one of a recognition of effort, a thank you to colleagues for their hard work over the last 2 years, and to recognise the impact on patients that improvement work has led to, particularly in areas like stroke, urgent care and our maternity services. And a specific thank you to the clinical operational teams in women's and children's and medicine for the work that they've completed. But it is a staging post to another place that we want to get to, which is to SOF 2 and beyond. Not because the ratings matrix is the thing that we focus on, but the areas we prioritise around patients first, quality, safety driven, clinically led, means that when we hit that approach right every day, the SOF ratings will improve. It is a natural consequence of the improvement work. And again, Chair, our ambition now is to move from SOF 3 to SOF 2 well and with evidence of sustainability, not quickly and to pass off an audit checklist. That is not the approach of this board, this organisation. And again, we'll hear a bit more about that later on in the agenda, Chair, about our SOF 3 to 2 plans, timescales and ambition. And my last message just to share, Chair, is the visit we had from the National Maternity Support Programme on the week commencing the 10th of October. And that was a positive visit designed to do a review similar to what we've had under the System Improvement Board reviews with the SOF 4 Recovery Support Programme. We're awaiting formal notification of the output of that visit. The ambition is for us to receive notification of moving into the sustainability phase of that programme out of the nationally mandated maternity support programme. We will likely get feedback on that, Chair, I would imagine pre-Christmas with formal notification in January. That's as much as I wanted to take the board on. Thank you.
Any questions to the Chief Exec on his report? No. Happy to accept the Chief Executive's report. Thank you very much. Then we'll move on, colleagues, to item 125, the Head Governor's report. And Shirley-Ann Wilson, are you presenting this? We have the paper in front of us.
Is it just to be noted?
Yeah.
Is it possible that I could just say something very? I don't know if am I allowed to speak?
Of course you can.
I don't know. Okay. I'm going to be very brief because of time, but the governors had a development day last week, which was led very well, I thought, by Paul and Tony. And we were looking at areas that we're going to be concentrating on in the next few months. We've got some new governors who I know you'll all be meeting, very enthusiastic, heartwarming really. But one of the areas that we looked at was how we work with stakeholders. And of course the board, you know, a massive stakeholder. So going forward, I hope and I think that over the next few months, we'll be looking at how we engage with the board. And I think that the COG are very much looking forward to perhaps working with you in a different way. But as I think I pointed out last week, that is a two-way process. And it's also about the board looking about how you interact and you engage with us. But I'm full of hope and full of optimism. So onwards and upwards, as they say. And that's all I'm going to say. Thank you very much for listening.
Absolutely. We'll take that as an update on your paper that's been presented here.
Okay,
So we
thank
know
you,
that in a minute.
Thank you, Chair.
Thank you. Yeah. Okay. Any questions for the Deputy Lead Governor? We're happy to accept the paper. Okay, Shirley-Ann, thank you. Please do speak up. Okay. So we'll move on then to quality and safety. Item 126, annual safeguarding report. Just before I ask the Chief Nursing Officer to speak on this, can I just check with the Chair of the Quality Committee that there's nothing to escalate?
No, we received this and discussed it and noted that, as it said in the paper, this is the report from the named nurses for adults and children, but we are going to receive reports, I think, in February. Well, we asked for some reports back from the named doctor, which refers to the named doctor, but we will also be receiving reports in February, I think, from the named nursery midwifery and for children in care, noting the issues that are raised in here about children in care. Although there are some issues in the covering paper about children in care and such, like we weren't alert to those directly in the quality committee, so we hadn't really discussed it.
The reason I've asked you for the quality is this is an assurance paper, so this is part of our assurance scrutiny. To you, Chief Nurse, thank you.
Thank you, Chief. Thank you. On that note, I don't think I have much to say other than this is a statutory requirement for board to be to receive an annual safeguarding report every year. And I'm going to invite Mark to just give us a brief overview because it's going to come. Mark Limpet, the head of safeguarding.
Mark, are you there? I can see your picture. Can you hear us? Hello, Mark.
Yeah, Tuesday.
Wait a second, colleagues, while we bring Mark in. Mark, can you hear me? No? Okay, then if colleagues are comfortable, I'll ask the Chief Nurse to forward this paper to us. Any issues outside of what the Quality Committee's looked at?
I think he is kind of aligned with the issues we raised with that the reports when it comes next time is to include space for managed doctors as well as we've got the organization and strength from the midwifery safeguarding. Those are the two issues that I think are from there. The rest of it, as you can see right from the executive summary, if we are at the right place for the organization in terms of ensuring our children and adults are safeguarded. I think Mark is there now.
Mark, can you hear me okay?
You're
No.
on mute.
Are you on? Melissa, can we just check the sound there with you?
I think it's something on Mark's end, unfortunately.
Mark, we can see you, we can see that you're speaking, but we can't hear you, unfortunately. No. Mark, we're going to continue with the board if that's okay. I've asked the Chief Nurse to present the paper and the Chair of the Quality Committee has also commented that they've scrutinised it. So if you just observe the proceedings, if that's okay. Assurance purposes.
Yeah, I just wanted to recognise it makes a point that we didn't receive all the information about the children in care issues and the figures that is here now, so we didn't receive those. But the issue that I wanted to highlight my concern was actually what's happened to the numbers over the last six months for children in care, that there seems to have been an increase, which, and I was reassured that we will be receiving a report in February, I think it says, from that named nurse. But I think that is something that we just need to, we will in the quality committee keep obviously review that when that comes, because that's, I assume that relates to the refugees and such like, and the complexity of some of the issues that are coming up in maternity. So I think we just need to keep a weather eye on that.
So if I summarise, colleagues, what you've got in front of you is the assurance, the declaration that the trust is fulfilling its duties and responsibilities in relation to a named nurse for adults, a named nurse for children and young people. What the quality committee have also looked at in more detail is the named nurse issues around children in care, maternity and medicine. That will come.
No, we will be looking at those in detail prior to the February report.
Yeah.
We didn't receive those in detail.
So they will come to the, but the paper you have in front of you is in relation to adults and children and young people, subject to the comments.
Yeah.
Colleagues, happy to accept those assurances.
Yeah.
Thank you. Mark, thank you. My apologies that we haven't been able to hear you, but the paper has been noted and assured and approved. So hopefully we'll meet again. Take care. Bye. There is a song there, yeah. Maternity safety update then, 127, report to update, continuing monitoring and action. Again, I'm going to ask the chair of the quality committee, anything here that needs to be raised or escalated to the board?
I think I'm particularly asked to confirm that we received the 4 papers that were in the in the reference pack. The workforce reports, that's actually a suite of workforce reports, and they were received to confirm that we were on course with that particular target in the maternity incentive scheme. We also received the maternity incentive scheme report, which is outlined that we are at the moment heading for 9 out of 10. But we did note in the quality committee that although the ambition is that by December we will achieve training compliance, there is significant work involved in achieving that. And I think the note that the chief executive has just made about the BMA and industrial action, that's probably the issue that could impact on those training figures. So I think we just need to be aware that it's not a given that we will achieve 10 out of 10 by February on the maternity incentive scheme. But that's what I would say. We received all those papers and didn't raise any significant issues about them.
And this is an assurance paper, so there's anything you wish to add or to bring anybody in?
I just need to bring something to sort of give a brief overview of the work paper.
I can see Mike Thomas, the chair. Can you hear and see us okay?
I can hear you. Can you hear me?
Yes, we can hear you. Thankfully. Okay. Chief Nurse, would you like to answer, please?
Jonathan, if you could just give us an update on all your film papers, please, and briefly as we possibly can to go through what happened. Very, very clearly. Thank you.
Okay, I will be as brief as I can. So in general, maternity update, just to note that the cultural diagnostic from the occupational psychologist at South Lakes Birth Centre has now been received by the quadrumvirate, so work will be ongoing with that. And in addition to that, a SCORE cultural survey has taken place across all maternity services. That the results of that have just come in, so we now have those results as well to work on. And following that, there'll be facilitated cultural conversations that will take place with relevant teams. The other thing to say is that as everybody said, the local maternity system took an assurance visit with us on the 9th of October to look at our CNST progress and also our compliance with Saving Babies Lives Care Bundle 2. Good progress was noted in both, and those assurance visits will continue now until CNST submission. The MVP chair stepped down in August, and we now have a new MVP chair appointed called Janet Gorry, and we've had initial meetings with her, so she'll now support us going forwards. And Aaron has already mentioned the MSSP visit that took place earlier. As we said in the in the reference pack, there are a suite of reports, all of which are required for CNST compliance assurance. So they all need to be brought here. And the first one is the ATTAIN report, which is required for Safety Action 3 transitional care. So just to report from that this is around avoiding term admissions to the neonatal unit and reducing the separation of mums and babies. So the trust rate remains below the national average, although there has been a slight rise in admissions at Furnish General Hospital. Themes have been identified in the quarter. There have been 5 avoidable admissions found, and on review, the themes were escalation of CTG concerns, babies taken for cannulation out of the room that could have been done in the room with mum, and also babies becoming cold. So there is some targeted work at FGH with estates where we've raised the temperature of the rooms to treat that. And we also looked at late preterm admissions to increase our babies that are eligible for transitional care. And this ties in with the implementation of 24-hour transitional care at RLI. Then we have the Safety Champions report. So this is a quarterly look back on the work of the Safety Champions. And just to note, Alison Cole has joined Karen Deeney, so we now have 2 non-executive Safety Champions. We're required to do monthly walkarounds to get feedback from staff, and in the appendix there is the detail of those monthly walkarounds. The only thing that hadn't worked so well really with Safety Champions has been the work with the MVP chair, because obviously we haven't had one in place. So now we're able to move forward with increasing our links with Janet now she's started. And then we're moving on to the workforce report. So the first one, obstetric medical, this is to support Safety Action 4. So just to say with this, we should audit compliance with the RCOG criteria for short-term and long-term locums. We should implement the RCOG guidance on compensatory rests where consultants and specialist doctors are working as non-resident on calls. This requires a 6-month audit from the 30th of May to the 7th of December. And we should also monitor compliance of consultant attendances for clinical situations listed in the RCOG roles and responsibilities of the consultant document. And again, there's a 6-month audit with set dates from the 30th of May to the 7th of December. So we can confirm from the review we are compliant with the criteria for both short and long-term locums. We're compliant with the first 3 months of the 6-month audit of consultant attendance, and we also regularly report this in the perinatal quality surveillance tool that comes with the pack. So we're confident that we'll continue to be compliant with that. However, we're not compliant with the RCOG guidance for compensatory rest. So the guidance is very strict for BMA, and the example they give is if a consultant at home is phoned at 3 a.m. in the morning for advice, we'd assume they'd get back to sleep at 3:30 and they would therefore not come back to work until 2:30 in the afternoon the following day. So that's obviously very different to how our other on-calls work, and we're just working on how we're going to do that. In order to be compliant with this safety action, what we need to do is bring an action plan to the trust board, so we can still report that we are compliant without actually being able to put that into place yet. So that report is included as Appendix 1 in the pack. For neonatal medical workforce, we're required to formally record in the trust board minutes whether we meet the relevant BAPA recommendations for neonatal medical workforce for tiers 1, 2 and 3 cover. And if the requirements aren't met, we should agree an action plan and evidence progress against any previous action plans. So what we can say is that at Furnish General Hospital, we're compliant with all 3 tiers. At RLI, however, we're compliant with tier 3, which is consultant cover, but we are not compliant with tiers 1 and 2 because we're requiring to have dedicated doctors in the neonatal unit. And at the minute, out of hours, we're sharing our doctors with paediatrics. So again, there is an action plan in the appendices. So there's an action plan from year 4, which we can show progress with as Appendix 1, and then there is a new action plan for year 5, and a business case has been developed in order to meet the standard. Neonatal workforce review for nursing. So again, we're required to formally record in the board minutes compliance with BAPA and nurse staffing standards using the neonatal nursing workforce calculator. So we can say for this one that both sites achieve compliance with the skill mix element of the nurse staffing standard, and Furnish General Hospitals receive considerable recurrent investment from the North West Neonatal Network and is therefore compliant with the direct patient-facing workforce standard, but RLI is not compliant with the direct workforce-facing standard. Just as assurance, despite this, the unit still met the BAPA appropriate staffing levels for 89% of shifts from January to June in 2023, which compares against an average of 80% nationally. An action plan was developed in year 4, and this is included as Appendix 1, and there's a new action plan being developed for year 5 included as Appendix 2. So as part of the review as well, we have identified the need for an additional role of a Band 3 neonatal data administrator, and a business plan is being done for this as well. And then the final workforce paper is the midwifery workforce paper, and this is for Action 5. And to highlight from this, we are required to do a biannual workforce look back review, which you've got in the reference pack. We've maintained one-to-one care in labour 100% across all of the sites, and staffing levels to shift fill and the acuity tool are over 85%. But this has only been achieved with considerable use of agency and bank. We do have a vacancy rate of over 22% in our funded establishments still in maternity. So one of the things we have to do is look at continuity of care, and we are required to not restart continuity of care until we have met our full staffing level. So we can confirm we have not restarted continuity of care. We do have an issue with home birth and home chase. We've got really an unacceptable number of nights where we haven't got on call. So we've got work ongoing with staff engagement to restructure our on-call service so that we can offer a reliable service to women. And then just finally, just recognition that in undertaking this review, we have become less convinced that our birth rate plus staffing review that we had done in November 2021 is giving us reliable establishments, and we have put forward a proposal that will repeat that piece of work. That's all my papers.
Thanks, Tamsin. That's a lot of detail there. We've got it in the report. I'm grateful that the Quality Committee has scrutinised this before it's come to the board. Thank you for that. We do know that the Board of Directors, before I come to question, are asked to make sure we're alerted to the risks, and I think you have alerted us to the risk in the report, Tamsin, but I'm just checking with you. Are we clear that you've alerted the board to all the risks identified in your report?
Yes.
Right, thank you. Colleagues, any questions then for Tamsin? No? Then I'll go very gently through the recommendations. We're asked to receive and approve the report for assurance.
Yeah.
The Board of Directors are alerted to the risks identified in the report. I think it's fairly clear around some compliance issues and staffing, etc. Just to alert the Chief Nurse that item 15 on the Council of Governors this afternoon, we'll be asking for an assurance report around maternity. So Council of Governors will be asking around stage staffing, etc. But we're happy to accept the risks have been brought to our attention. Yeah. And that the sustainability plan for MSSP exit is drafted. So we're asking to approve that the exit plan has been drafted. Yeah. When will we see it?
This is the dirty part first, and then you'll see it probably good. How it's going to work is going to be really awkward because the 29th of November is the date when we have to present that plan and our board. So, kind of in which perspective, unless we can figure it out.
What I would recommend is that the Quality Committee, I think the timing is quite sure do that on behalf. But once that's been through the Quality Committee process, it will be an opportunity access within the circular.
That's what I was going to suggest, Jim.
Okay, so board happy with that there will be a sequence of scrutiny, a correct sequence of scrutiny that will be organised outside of the board by the company secretary and the chair of the Quality Committee and the Chief Nurse, and that the scrutiny is related to the MSSP exit. Colleagues happy with that? Yeah. Thank you for that. Okay, then colleagues, we'll move on. We're on to performance and resources. Tamsin, can I just say thank you? And just to let you know before you go, several of the NEDs are receiving contacts and reports of the work that you and colleagues are doing with patient groups, with mothers and babies. We're very, very well aware that when we receive these reports, when it says there has been an injury, and you know there are real people, real mothers, real babies, real families at the end of these reports. But just to thank you and your colleagues for all that you're doing. Could you please pass that on, please?
Yeah, thank you.
Okay, colleagues, performance and resources, we move to the Deputy Chief Exec, item 1281, integrated performance dashboard and report number 5.
Very short introduction from me, Chair, for a handover to Chief Institute Medical Officer for the quality and safety section of this month's report. I don't intend to read out the identified highlights and headlines, which again set out the executive summary report, but I do want to just draw the board's attention to the notes on the very helpful meeting held at the beginning of October with non-executive directors and some of the further developments discussed, which will further supplement our IPR over the next few months. I think it's a really good practice in terms of how we keep the development and of this really strong product going forward. So you will start to see those changes there, or it won't just be a single, here's a new version. Also, we've specifically incorporated data in respect of the numbers of patients who do not meet the criteria to reside, and also formally noted the escalation actions taken, some advance notice and some changes to the way that this issue will be quantified according to changes in the guidance nationally, and this will be reported in the uniform from the month 6 September data pack. So that was it for an introduction, just highlight those points, and I would like to hand over to Tabitha and Jane. Who would like to go first?
Thank you, Chair. I'll go first and mortality and BC like we normally do. So I'm going to assume everybody has read the IPR, and I will just focus on areas for escalation and the work that we are doing. As you can see from the executive summary, we started with complaints, which is like a public relations kind of indicator, and it's been a concern and a challenge for us throughout the months. So work is continuing around complaints in looking at how we can strengthen and respond to our patients. So I did mention that we were reviewing the process, and now the issue we have is capacity and capability within the complaints team. So there is ongoing improvement around it, but you have to bear with us that the team at the moment is in the process of recruiting to strengthen our PALS responses and also strengthen the complaints team itself. However, there is good news that in terms of complaints exceeding 6 months, which were in our 50s and everything, we are at the moment down to about 7 complaints that are over 6 months. We are continuing to try and speak to complainants face to face wherever possible. And like Paul said earlier, right in the beginning, we're going to sort of bring a report because we've had MIA audit into complaint. We went to audit committee 21st, audit committee, and the report from MI went. So we will bring something to board in December. It's cool. I just wanted to highlight that. In terms of our fundamentals of care, which is the falls and pressure outbursts, we continue to see small steps into improvements. So over the month of August that we're looking at, we had 116, and most of the fallers are probably one person because, and they are mainly within our older adults and frail patients. So we are continuing to do some improvements and incorporating like capacity assessment. Do these patients have capacity? Do these patients meet criteria to revive? So there is a lot of work in the background, which is going to be taken through the quality improvement methodology to see how we can support boards and teams to continue. Pressure ulcers category 2 is what we've reported over the months since I've been here. But unfortunately, we've had one category 3 pressure ulcer. And the reason why I mentioned category 3 is when it is 3 to 4, we have to report it as a safeguarding. And this was a 95-year-old gentleman with multiple comorbidities. But we are really working to continue to improve not just equipment to support pressure outlet, but train the staff in terms of how they use pressure relieving equipment. Family and friends, the national requirement is 15% for an organization. We're still sitting at 30%. And we are continuing again to enrich into clinical areas to try and get patient views whilst they're still with us before they go home. So we are, it's a slightly improved from what I reported last month, and we will continue to focus on that. And I shall pass you over to Jane for BTE and mortality.
So BTE is first. So as ever, we're not quite done with BTE. We still have a lot of work going on with our BITs. And what we're doing is that we've actually got a meeting with our clinical leads tomorrow evening, which that this is on the agenda. But also to revisit what we've done so far and look at our processes. It turns out that things like the BT assessment on the day is only measured on the day. However, most of our issues are going to get 91% around day care surgery. It may well be that they've had their BT treatment, but it isn't measured. So we just want to make sure that we're not pursuing something that actually is a technical issue. But also things like how patients leave the ward to go to theatres, they will have a checklist of things. We need to make sure that BT is one of those there. So there's some work going on. We have a new clinical lead BT who's very engaged with the surgical team, and they're actually looking at patient level information to work out why there's an issue with the patient not being the assessment. So a lot of work ongoing there. When we move on to mortality, our overall mortality remains very good. And our two alerting groups, there's the acute cerebrovascular disease. We know that was going to take a while before that comes off, but there's a whole process that I think Josh is leading around us reviewing those again, because we've not been able to identify the reasons why that isn't quite yet, and it's not accounted for. So we're going back to look at 400 deaths around that. The other one was around the superficial contusion, superficial injury, which we thought was related to coding. Well, certainly that's now to be an abnormal less than particularly reducible. So we are confident that that will move in the next 2 months. And that's it.
Chief People Officer, thank you, Chair.
Thank you. So just in terms of vacancy, we have moved into special cause variation with a cause of concern around the vacancy rate. And we have got a piece of work that's been commissioned now to look at what the issues are around that, particularly from a thematic perspective and hotspot areas. So we know that our unregistered clinical workforce is an area of real concern for us, and we're working now with all of the care groups for them to complete the assessment of using the NHS England recruitment retention toolkit, to just look at if there are any things that we can pull out from that in terms of thematics that need to be taken forward into particular action. And there'll be a paper that comes into People Committee this month for that. We've also got a review of the recruitment processes complete bit that's undergoing at the moment. That's due to complete in December, and the focus of that is to look at where there are opportunities for us to streamline and improve the processes, but also where we're looking at how we can improve the candidate, the applicant experience as well. So that work will complete in December, and that will also then help inform some of the work that happens in the shared services work, as recruitment is an in-scope service for the central services programme. In terms of absence rates, I just wanted to pull out here, we can see that absence rates are increasing, and that's aligned primarily with the seasonal trends that we would expect over autumn and winter, particularly with an increase in cold, flu and COVID related absences. The winter seasonal flu and COVID vaccination campaigns are well underway now for colleagues, and it's probably worth noting that the take up of the COVID vaccination is significantly lower than the flu vaccination at the current point in time. Again, there'll be a paper that goes into People Committee in that respect this month. And then just finally, I said last month about the really positive work that's been happening around the reduction in agency use for the nursing workforce. We're now at a 3-year low for the use of agency nursing, which is a fantastic achievement. So the challenge now is to continue with that over the course of the winter. We had forecast and profiled with some really significant recruitment activity that had happened that had resulted in us filling some long-standing medical vacancies in particular, that we would achieve that 3.7% agency ceiling by the end of the financial year. With the winter plan that's in the agenda today and the requirement for some additional use of agency resource there, it is highly likely that we'll now exceed that 3.7% ceiling on the back of the requirements for that winter escalation. And we are focusing now because clearly we were getting benchmark data now from systems about how we compare with other organisations around agency use. So we've got some pieces of work now that we started around reviewing, particularly the medical locum rate locally, and also seeing if we can get some alignment or further alignment across Lancashire and South Cumbria.
Finance Chair. So the trust remained on plan at the end of month 5 as set out in the report, although it's noticed that the phasing of the plan stretch target will have an increasing detrimental impact on the month financial position of the remainder of the financial year based on our current year-end forecast risk assessment. That process, of course, isn't complete. We are working very hard to mitigate financial risk, and we'll speak more about that later. A process for establishing a robust, best and realistic case outturn position based on a number of key criteria and independent peer review. Effective governance and oversight has been established for all providers across our system in response to the agreements reached at the PCB programme board. But also this is a process that will meet the specific requirements set out by the Regional Chief Financial Officer in his letter to the Integrated Care Board Chief Financial Officers this month. The board will be briefed on this and our latest forecast risk and opportunity later today, and the output of that process will come back to this board in due course, in line with the prescribed process and timetable. Once those are confirmed, that's a process that we're discussing with regional colleagues. We have also identified increasing pressures associated with the agency spend. I won't repeat what Ali said. Obviously, the winter plan gives us another problem in that regard. However, the controls and processes that we've established are designed to make sure that that's managed as effectively as possible. We're currently working through a number of moving parts in respect to the trust income position, not least the implications, some changes to the way that elective recovery funds are allocated or flowed through into systems, and the full financial implications also of industrial action to date. We'll seek to clarify all sorts of points through our formal forecast review. Whilst industrial action costs in the earlier part of the year were offset in the expenditure run rate, this has reduced the extent to which the trust has been able to mitigate this stretch target. This plus pay award expenditure that's above the specific defined increases in the trust's income contracts made unplanned pressures are therefore creating additional financial challenge and risk, again, which is incorporated into the forecast risk assessment that we've reported in the past. Just a quick point on cash. The board approved the application for cash support previously. As a result of earlier than expected income receipts and other positive factors, I can advise the cash support was not drawn down in October and has not been applied for in November, but we are still anticipating acquiring cash support in December. Chair, pass it to Chief Operating Officer.
Thanks, Chris. So for stroke, we see the sustained A SNAP score at Furness and B RLI. That's validated for Q1 and unvalidated for Q2 of this year, and 1 month into Q3 continues the case. Diagnostics, you see the 8 consecutive points better than target, especially for us improvement. Cancer, I would characterise as stable and improving. You see the new targets hit
the IPR in January, I described at the last board, and there's some excellent progression you've seen from the benchmarking data, and that we're first or top quartile peers in many of the metrics. Access to elective care, similarly, the things I've drawn out, I have to say that we are still on trajectory for 65 weeks on 109% elective recovery performance, and that's challenging with industrial action, but we're confident in that space. I'd previously alerted the board to the specific risk we see in restorative dentistry, and that we may see some 78-week breaches in that space that we're trying desperately to avoid. And you'll note that certainly for the first time in my time here, you'll see 2 points of special cause improvement in DNAs, which significant improvement in patient-initiated follow-up. And as mentioned earlier, we're amongst the best in class in patient-initiated follow-up. For urgent care, these are August data, so you'll see that we remained in common cause variation, as you might expect, at 73.5%. As Aaron described earlier, September and October has seen expected the early coming of seasonal winter across the NHS, and so we've not been in a place where they've escalated to Opal 4, but we have seen significant pressure. Certainly, attendances for each of the last 6 weeks in Furness in each of those 6 weeks have been higher than at any other time since COVID. So we are seeing a growth in attendance beyond that we would expect. So performance, we've just finished October unvalidated performance sits near 70% in that space. So you do see the urgent care system under pressure. We'll talk more about that in the winter paper later in terms of things that we might do to mitigate that over the real depths of the seasonal winter period in January. Ambulance handover, it remains in 30 minutes, remains a special cause improvement, but at 74 to 79%, but still short of the 80% national stretch target. Not meeting medical criteria to design, optimism at the end remains at 16 to 18% in the data, but is rising. Today that's 130 patients, 22%, and we will follow that in more detail certainly in the winter planning paper later in this agenda. And I was asked specifically, Chair, to just maybe thought it was straightforward or not, to describe what not therapy fit means. So I'll have a go. So simply, we've got 600 patients in our trust today in general and acute beds. And the 130 I've described are those that don't meet medical criteria to reside, i.e. they don't need a thing from a doctor today. And there's a very set of criteria that describe that. Are they on oxygen? Do they have an intravenous infusion? Have they had medication started in the last X amount of hours and so on? There are another group of patients who have finished with their medical care, so to speak. They're still supervised by a doctor, just for the avoidance of doubt, while they're on care, but they're no longer in need of medical interventions. But because of the patient's clinical condition, then they are not yet fit for therapy. So if you imagine, for example, a stroke patient who has had significant input from a stroke physician, that significant input, but they still remain under supervision of that stroke physician has finished. So there are no new interventions, but the patient may have a disability that requires a level of inpatient therapy, so they're not therapy fit. That then splits in two, where there will be some patients who will need therapy in hospital, the minority, and there'll be others that should we have a commissioned service for therapy in the community, could be discharged for therapy in the community, which would clearly be preferable. The reason for having all of this conversation is there's now a change in the codification of not meeting criteria to reside. So today, I would spend 130 patients who don't meet criteria to reside. The new codification will change that to the 200 I've described who are also not therapy fit. You'll see that change, you'll see a spike in the graph, and you'll say what happened there. It's a codification change. Ultimately, it does mean that 200 of our 600 beds today are not accessible for new patients, because the patients are either not meeting criteria to reside and requiring residential or domiciliary care, or they could be having therapy where it's commissioned outside the hospitals. So happy to take questions on that. It's complex, but I would ask to try and define that today. Otherwise, Chair, that's my update. Happy to take any questions.
That's the report, Chair. Thank you.
Okay, a local question. You?
Yeah, that was one of my questions about what, but I just want to clarify that I've got a few questions, but I'll take perhaps a couple now, Chair, and then I'll come back to someone about cancer. So I've got a question about that. So I fully understand it. We're actually about to start reporting really the true position of people who are in our beds who, if there were sufficient services outside of hospital, they wouldn't need to be in hospital.
Yeah, that's okay.
So the figure that we've been previously reporting has actually not counted those people who could have been home if they could have had their therapy at home.
So it's had fidelity to the not meeting criteria to the right definition.
Yeah.
But your characterisation is fair, yeah.
So actually, this will actually give us a true picture of if the services were available in the community in terms of domiciliary care, residential care, therapy services, which may actually not even be commissioned.
Indeed.
But as I understand it, those people who are not therapy fit, that's the right term, are receive the therapy that they could be receiving in the community. They are receiving that therapy in hospital, are they, or do we not have the resources?
So there'll be a small subset who remain clinically unfit for therapy, but those where there is no commission service in the community, yes, of course, they will receive an element of therapy.
But obviously that puts pressure on our services that actually ideally would be directed towards the people who need it in hospital. Right? So I think I understand that, and that's probably a really important picture for us to be moving forward to, and so that puts us up to about a third of our beds. Right. Okay. Yeah. So that was a clarification, Chair. The other point I'll make now, before later asking a question about the cancer stuff, is that in the discussions we had with the Neds and with Chris and others, which was, I would say, from a Ned's point of view, was really valuable as well from our point of view. The other issue that's not perhaps highlighted in the covering report is the issue about rebasing I never know what to call it, but the line on the IPR, which we go either side of to become blue or orange, which frequently isn't the same as the if you've noticed that, it's often a line that says the target is, and often the line that we're measuring whether we're going orange or blue either side of is quite a way below the target. And for some of those, the logic is that we need to be quite rigorous about rebasing that line, because we get a false sense of assurance when we see lots of blues that we're doing very well, but actually we're still well below the target. And that's when in the assurance report we have that we're actually still failing to meet the actual the target. We may be doing better, but we're still well below the target. And things like, I think, the ambulance 30 minute, which we're doing really well, improving, but we're still not below it, just an example. So I think I just wanted to highlight that. Well, just so you don't get bored of my voice, I would come back to the council later.
Make a good point though here, we're out of softball, we're in SOC 3, but that's a really good example of the challenges we face to deal with meeting the national standards. Good point. Bring the Chief Executive.
Thanks, Chair. Just a couple of quick points, if I may. So, on a similar theme of that 3 to 2 journey, within the quality and safety reports that Tabitha and Jennifer highlighted on, the 7 complaints over 6 months, the friends and family at 13, not quite at the 15, and the BTE perennially being just off. I'd really like to see a trajectory for what we need to do to get to a position of delivery with the assurance committee, please. Because I think that's the most important one. We've had a similar update, and all the work's going into it. Would be good to just get that kind of sense of when and where this might start to achieve the targets, because they're very close. Ali put in her report the 3.7% agency cap delivery and the risk for the winter plan in how we're planning to deploy resources potentially over that period. I think the board needs to be cognizant of that decision when we get to it, that there's a risk there when we make those commitments to not achieving some targets that we've been asked to achieve, and that needs consideration. My reflection of that is I think we need to be clear as a leadership team that apart from temporary escalation through winter, we would and have achieved the 3.7% threshold. So I think we can narrate risk and mitigation, but what we can't say is that permission then to just blow the 3.7% and go. So I'd like some discipline in that winter plan deployment. And then my final point, Chair, is the issue of the not being criteria to reside, not priority fit. There are a couple of programmes of work, and I took an action, Chair, from the last board to escalate on not meeting criteria to reside in particular. I've had formal notice back from the ICB after that escalation, which points to strategic pieces of work, clinical strategy, primary care and community transformation, the whole system flow programmes of work. And whilst they are the areas where the board should be supportive of medium and long-term solutions to these issues, we haven't had a response that allows us to mitigate the risks in winter with those numbers of patients in our beds. So I'll be taking up a second conversation with you on that point, Chair. But just to recognise when we talk about our medium-term plans, those transformation programmes in the system designed to reduce those numbers significantly, we need to be playing our full part in delivering those.
Kristen, Tony.
Just to link to Aaron's point, because we've been working hard to achieve this 3.7%. Remember, as an organisation, our plans were required to be based on a certain percentage of criteria to recite, which was 5%. The fact that it was so far away really impacts on our ability to flex our capacity in this way. So it inevitably puts that indicator under pressure, but notwithstanding, we've got to do our best to still achieve it.
We have to be very sensitive to mitigation and incidences and activities that impact on our drive to meet standard metric. Balance that with the sensitivity, doesn't normalise it. So Scott talked about Local 4. I know, not here, but I know of other organisations where there's almost a sense from the outside looking in, they're normalising Opal 4 as a normal opera, whereas actually Opal 4 is abnormal. And equally RTTs, ambulance waits, stuff on finances, particularly the SIP, the run rate. I think the board needs to be sensitive. Yes, we accept there are mitigation, but we mustn't normalise it. The drive underneath it has to be what Aaron was pointing out. Where are the date lines? What's the timelines to meet these scores? And even if there are mitigation, how do we then mitigate the mitigation so that we still achieve the standards? Don't fall into the trap of saying, well, we'll elongate standard goals because the trust has done that in the past and actually it's become normalised and then we don't achieve the goals. So I think focus will remain on meeting those targets and standards. Okay. So,
yes, Aaron, I mean, thanks for the update, Aaron, regarding the criteria to design. Was that ICB response inclusive of the local authorities?
It was, Tommy. So there's a recognition that the medium-term pieces of work will include local authority commitment on future change. There is still going to be a number of meetings between now and December with system leaders on winter preparations, for example, and mitigation. So the letter received was from the ICB. It includes reference to the work that we do with local authorities that I referenced earlier. I'll be picking back up with the ICB this week on that stuff.
And just one supplementary. Will that work as some data analytics in terms of looking at investments from local governments in line with what they, in inverted commas, have investment for to spend, in line with what they are actually spending?
So I understand that's been picked up within the Recovery and Transformation Board with the review of things like the IBCF and the ring fence allocations to social care to support the partnership integrated work with the health service. So that's an action that's been picked up with the Recovery and Transformation. Thank you for that.
I think a minute to add on to that, Tony, the PCB, the Provider Collaborative Board, has requested through to the ICB that the local authority leads on the transformation will produce an update report on those. And just to add something else, just for your information, Scott, in the meeting yesterday I had with the Patients Partnership, they are approaching the ICB, looking to develop a project on how carers can support criteria to reside and faster discharge. And they'll have to do a scoping first, so it will take a bit of time. And again, for information, colleagues, there is an accelerator reform fund. You may have been aware of it. 42 million that's been given by the government to the local authorities across England. There are 12 priorities in that accelerator reform fund. I think we'll be supporting the ICB to probably identify 2 of those. I think it's right that we should highlight that one of those should be the criteria to reside. I just check around the board here that we currently do that approach. And we will absolutely, I look to the board again and say we'll support the Patients Partnerships work, carers work in that criteria to reside space. So it's just a learn here, Scott. Thank you. And Sarah, please.
Thank you. Can I just, Aaron, you can use an acronym there, which I don't know, which is IBCF.
Yeah, it's the Integrated Better Care Fund. So I'm going back in time now, but that was a central investment into local authorities and health to decide how best to use some of that investment for general population health improvement, etc. So if it helps, Chair, we can circulate some guidance on the IBCF history and what it's utilised for.
Yes, that's cool. Thank you. Aaron picked up my question. I was going to ask about BTE. Sorry. The other question I had was around finance. And on page 84, we talk about continued assessment and reconciliation of the contract offer for 23-24. I'm just mindful that at audit committee 6 months ago, when we looked at the end of year report by the external auditor, this was an element they picked up as being something that the trust should be cognizant of, because we're operating in an environment where we don't know what our contract offer is. So looking for an update and some assurance in where we are with that process for 23-24.
There are two things here. That one is the main point of that reconciliation work is about the fact that the ICB needs to rebase contracts as we come out of the contractual form from the pandemic through into a new form, and the ICB's had permission to basically maintain a level of block contracting through this period. So that work really is about looking forward rather than the point we raised, Sarah, which was raised through the audit, which is at the end of last year we didn't have signed contract. I've chased it actually today because we've been asked to accept a variation to our contract, and my point is that I'm struggling to accept a variation without the contract to vary. So I've just asked for a time to conclude. I understand why it's taking a bit of time, but I'm pushing the defined timeline for us to be able to pin that down. It doesn't affect our income. The income is passed through in line with the contractual expectations, but I absolutely recognise the need to get the contract completed and signed, and I will escalate that.
Thank you.
Karen, please, and then Zach, please.
Thank you. Thanks. Thanks, Chair. Just 3 brief questions from me. It's excellent to see that there's work underway to introduce EDI and particularly neonatal metrics into the IPR. I just note there isn't a time frame around that, and appreciate that might not be possible to specify today, but it would be very useful to understand the time frame for including those metrics in the IPR.
We take that as a note to the board.
Okay.
Nothing, so we'll take it away and provide the deadlines.
Thank you. And the second one, just in relation to recruitment, I'm conscious we haven't, or I don't think we have, taken a board report on communications and our communications activity and effectiveness. I just wonder whether there may be more to explore in the interface between how we manage our external comms and recruitment, particularly as we move into SOF 3 and 2. So I wonder whether that's something we could explore and hear more about at board.
I'll take that outside of the performance reports, Karen, if that's all right. And I'll
Absolutely.
discuss it with the chief exec and the company secretary outside the board.
Yeah, absolutely. And the third one is just with regard to the increasing rate of vacancies in midwives. We know that that we have appropriate and safer staffing levels in the units, and that all women are receiving one-to-one care, and that's delivered through agency and bank staffing where necessary. And we know also we've got an improvement trajectory in place to be in a much improved position by December, and that will be very important for our sustaining the fantastic improvement that's been made. It's just whether this rise that we're seeing in midwives vacancies is compromising that trajectory at all, and whether we need some additional action in place.
Ali or the chief nurse, please.
It is something we're looking at, Karen, and thanks for that question. Yesterday, I actually had about 40 midwives looking at why we have got that increase and what options we can do. Some of it is the way I think you had something talking about the on-call for community midwives. And some of it is for covering the obstetric sections, which is the inpatient one. So we are looking into it. If there is a few turnover, Ali can help me on that, because there's quite a few who have left. I don't think it will compromise the trajectory as such if we can manage the turnover versus what we've got.
Yeah. Should I just follow up? I
Yeah.
agree with everything Tabitha said there, and I think we also have to recognise, I think Tamsin also referenced there the work that we've got now with the outputs and recommendations from the cultural diagnostic that happened within Southlight Birthing Centre. There's replicability across other services for some of those recommendations. So as we start to implement some of those, I would hope that we can see the retention improve within maternity services, but we have to recognise that there is the improvement trajectory is predicated quite significantly on the number of students who qualify and will be employed in the organisation. So we've got it in plan. We can provide you're probably better to kind of give you something more detailed outside of the board.
Yeah, please. Yeah. Okay. Okay. Thank you for that. Okay, Sackville, with you, please.
Thank you, Chair. Again, thank you, colleagues, for a very, very clear IPR report. A couple of observations. One relates to the SHME and HSMR. Probably Jane wants to comment on it. And the other one is overall sort of summary understanding that I'm deriving from it. The HSMR SHME being, although they are green because they are below the peer groups in all trusts, it does look like the SHME has been going down and now there is a rising trend. And particularly the difference between HSMR and SHME, the standardized hospital mortality index being the SHME also covers deaths 30 days following discharge. And that seems to be going in the wrong direction, although at the moment it is well below the peers and the old trust. So that I just noticed that. I wonder whether that also is related to all the other things that we've just been discussing, like not meeting the criteria to reside and the pressures in the staffing and the performance. Generally, much of the key indicators in the exec summary, that seems to be going slightly in the wrong direction, which makes me wonder how much of this, or to what extent, the board can be assured of the actions that the organisation can take or within the realms of the organisation, and to what extent some of these things are impacted by wider context. And I'm not sure whether we can differentiate it in the way that it's presented. So I just wanted to flag that up, colleagues. Thank you.
Good observations, I think, Sakti. I'm going to ask the Deputy Chief Executive Director who should respond.
I guess it's just to say that the SHME, you're right, you know, it's up and down, it's less than 100, so it still remains less than expected by and large, and it is less than, say, our peer group and all trusts. Within that, there are a number of alerting groups out there, so we're not having increase in numbers of alerting groups. So my relatively simple arithmetic then would lead to believe that we've just got some variation within our groups, but within what's expected. I would need to take a bit more expert advice really to know whether or not that's something that overall we need to look at, but we're not having increasing of groups, particular conditions. And that's balance, which I can say, but you're right, whether Ishmael and HSMR are the best measures is a whole different discussion, I guess.
Just before I ask for the text coming, I'll just check with you, Safi. My understanding of the point you're making, if you take the 3 A's, the alerts that we get, we're picking those up where relevant, but the general helicopter view that you're giving us is there are declines around staffing vacancies, around RTTs, around the finance picture, etc. So I think what I hear is what you're saying is if you take the general view, what is the assurance and board work that can be taken to deal with those, but not necessarily that they're being alerted to us. I think that is that right, exactly?
Yeah, that's right, Chair. And to what extent they are really within the control of the board and the organisation, and what factors are beyond. And that's another thing that strikes me, really.
Chief Nurse?
Thank you, Chair. I'm just responding in terms of like the staffing, nursing staffing is the lowest vacancies that we've seen because our staffing level like 0.3, which is about 7 vacancies across. Where we're seeing a rise is the midwifery one, which we've already talked about. So, like Jane says, I suppose it's something we can think about and sort of triangulate in terms of like the issues around either safer staffing or everything. Midwifery, yes, is the cause of that, and we've got some improvement work around 17.8%. Actually, it's like that's continuing at the moment. But I just want to give assurance that in terms of nursing, let's say, and you know, our vacancies are the lowest that we've seen in any trust. So,
okay, thank you, James.
So I was just going to come back and say, you know, I'm more than happy to have a discussion if you think there are better ways of us representing things that are a bit more meaningful than the overall HSMR and SHPE, which are a bit bland at times. And I know you have such a sweet agenda, you might go to give us more.
Yeah, Chris?
We've tried to look at this sort of a general themed point before, and it's very complex and difficult and actually can lead to all sorts of problematic conclusions. I do think we can probably re-look at the sections to try to get an assessment of this, and certainly in our review process of the narrative, the production of the narrative. We do look and I'll ask for a refresh of if we've been saying something, you know, where have we been specific about timelines, have we been about trajectories, trends such as that. So I think if I can take Safi's general point as a challenge in a way to just have another look at it. What I do want to avoid, you know, we've been quite careful to connect to the principles of the IPR based on how you should use the data, avoiding exploiting more of the rest of it. I also think that some comments, so like say finance indicators going up against a profile of pressure linked to things like industrial action and all the rest of it. So I think that there's context that's important to any response in that way. So I think it needs a bit more work.
I think that's what Safi's steering us towards, really. You know, we get the individual reports, but what is the joined up view? Thank you, Safi. I think that will lead to some action points. I know Sarah, do you want to come in, Sarah?
Thank you. Just to follow up on that, I think through policy committee and then to board, we get the consultancy report. So that gives us a different route to assurance, which I think we just need to consider as we're thinking if individually and the NHS are the right thing. We have got other areas of assurance. And then similarly, we have the report that is triangulation of different learning that we have from incidents, complaints, PALs, etc. So I think it's also just making sure we don't just focus specifically on the data but look at those wider assurance pieces that we receive as well for quality.
That supports exactly that thing.
Thanks, Joe. Wanted to come back about some accountability to the point that Sarah makes. I've highlighted on our report that we received that report in 6 months. Safer staffing, nurse safer staffing report, and didn't identify any correlation between staffing levels and fall off in quality metrics. Perhaps with the proviso that nursing staffing is best of all the groups within the trust. So, council ones, I've got some questions that I've really not necessarily answered, but really whether the performance committee are actually looking at these, or whether if not, that they perhaps could. Because when you dig into the cancer data here, what we see is that urology seems to be struggling with both the speed at which people are seen and diagnosis and treatment. And there is the note here that there's a classical finish group of clinical input and perfect prospect pathway and such have been introduced. But I just think that performance needs probably more detailed scrutiny at some level, and just want the assurance or the reassurance actually of that taking place. The skin thing seems to be having seems to be seeing people quite quickly, although there's an issue about the change in the community dermatology service and what impact that might have. But it says that the diagnosis is quick, but it's quite speedy and an appropriate timescale. I have to say, as a GP, the issue it seems to be quite an issue with people being seen and then having what we call a biopsy, which confirm the diagnosis. And I'm not sure if that's being confused with treatment. And you know that. So how that's counted, because my patients often seem to think that they're going to have a treatment, but the letter suggests to me they're actually going to have the lesion removed in order to make the diagnosis. And there is a difference between the two. Sometimes the removal of the lesion for diagnosis is actually the treatment in itself, but quite often we diagnose something that then needs significant treatment. So just some queries about the skin performance. And finally, gynecology, which is probably my one of most concern, is because their issue really seems to be an issue about time to treatment, and that what it says as the action is that improvement trajectories to be established for cancer 2-week wait and cancer 28-day after diagnosis. And I think that's quite general to say that improvement trajectories are to be established. And I would just be grateful if probably the performance committee could just follow that up with a little bit. So Scott might the only other comments I wanted to make is that the glossary needs updating to include faster diagnosis standard and cancer patient part of this. I personally don't know what the last one still means, even though it was explained to me last time. A quick glossary could just be updated.
Do you comment on Stephen? And then Jane.
So I guess there's some of that here that's difficult to respond to in general terms. So I'm not sure I'm in the same place as in your assessment of urology. And when I look at 12 2-week breaches and for 2 weeks generally, with second is interferable. So I can understand more about how you synthesize those urology data. Dermatology, as it says in the pack, yes, you see a very significant increase in the most significant increase in demand of 25% increase in referrals. the step change that happened in August in terms of the use of artificial intelligence and photograph technology will get skin over the line with some headroom. Gynecology, I think it does actually state explicitly that there's timelines projected as it will be locked in by the end of October, which was yesterday. So without doing it in the board, I guess I think there's a number of things that could be talked through, and was keen not to deep dive into them all, but I think there would be reasonable explanations for the things you've raised, if there's more detail that we could go into, but perhaps not both.
So that was my specific request, was not to deal with it here in the board, was actually to make, to just ensure that it was being dealt with, because gynae, urology does appear at second to the bottom on the 2 weeks wait.
It's the 28th, they're not doing.
Sorry, I'm not going to get into it today, but on the chart I've got even 2 week wait, urology second to the bottom. But it's so I don't want to get into it here, but I just think that the chief executive looking at his plot before, and I think I just made a request that they could be taken outside. I didn't want them to get that detail.
We ask you to speak to Hugh.
I'll speak to Colin Raycroft.
Jane, comment?
So, well, I can speak outside as well. I was going to call up urology, because urology is probably one of the most pressing pathways nationally, and at least a third of most places breaches are related to urology. Much of it is around the diagnostic pathway. Much of it is around the necessity now for the MRI bit of it, and that's what the pathway is working at. Tim Briggs and Girth are actually looking at that pathway. They're also about to produce yet another new prostate pathway they're looking to work with. But we are working with the radiology team around trying to maximise the making it as much nearer one stop as possible, bearing in mind that all 3 sites can't have stops because of this, so it might end up with 2 stops at your MRI first. So they're doing a lot of transformation work around that, and radiology is supporting it. But yeah, urology is a lot around numbers on the.
So we've had discussion on.
I'm very happy with that.
Okay, thank you. Quick 2 things for me. One for the chief nurse. The 93-year-old gentleman with multiple comorbidities who had the level 3 pressure ulcer, and it says there are several lessons to learn, appropriate actions have been taken. Is that assurance? Does that appropriate action then prevent reoccurrence, and is the gentleman recovering?
The gentleman is recovering, and it's assuring in terms of the care that he was given, if that makes sense. It is assuring that it won't happen again. It's the improvement work that we're putting behind in terms of our older and frail patients, including strengthening the capacity assessment and their mobility assessment. So there is improvement work, and I took our point on board. We will come with time table in terms of where we do it, but the gentleman.
Thank you. Quick one more general point. Keep an eye on our forecast. This is 5-month financial forecast, and keep an eye on our CIP as we go forward, because what we get through the performance is a snap of where we are at those periods in time. But obviously, in due course, very shortly, the board will be discussing next year's budget and next year's budget planning. So just request that the board keep a close eye on what's happening around the CIP, what's happening around our finance plan as we go into the second half of S2 and quarter 4, really. Because there will be, I think, taking on Saturday's point, some repercussions of where we are now to how we start to plan next year's budget. Okay, colleagues, are you happy that we covered everything that you wish to in the performance reports? You have the assurance that you are seeking were relevant, and there are several action points and points to discuss outside of the board. Thank you. Thank you for that. I shall move on then to item 1282, the 3A reports from the Assurance Committee. Start with audit. Tony?
Yeah, thank you, Chair. So I'll speak to the salient points of the paper. And our audit committee, on the 26th of October, we went, internal auditors provide an overview of 3 reviews. One was on capital programme, that was predominantly around methodology, process and decision making. More work to be done there, but they're assured of the process and progression made. Complaints we've heard from the Director of Nursing, so triangulation there between positive progress that has been made in terms of response time to the plans that were in place, and then there was risk management self-assessment. Again, the internal auditors were assured of progression being made against those. NHS England fit and proper person test. Essentially, we can approve changes to the trust fit and proper person policy. Good to know that in terms of the trust, where our arrangements are pretty robust already. So it's a kind of revision rather than a major rewrite. In terms of the financial services update, the committee noted the work, but we wanted more updated progression on the overpayments of salary. So we were helpfully advised that there'll be a paper coming back about benchmarking and about the trend analysis of overpayments, with some trajectory on that in terms of improvement to our satisfaction. I'm forward around emergency preparedness. That's on the agenda today, the self-assessment, so we were sure about the progression made on that. And then the trust major incident plan, we were assured by the work to date, and pleased to see that it's been tested quite thoroughly, should we say, in recent times. The final point was around the back quarter 2 report. We had to reconvene an additional meeting in the week to go through that to the right standard. It was a thorough examination of the content of the agenda. And there's a minor adjustment as well as some issues identified going forward. The issues identified, which are not included, but for further conversation around estates, capacity strategically, because obviously we're doing some brilliant work across the system in terms of the ICB, but obviously that's how that will be planned for and maintained going forward. Workforce, because of the profile of the workforce, and also well-to issues around trading programs that are stopping or changing, and public health inequalities was also an area identified. We've also asked the company secretary and the deputy CEO to review and align the process to ensure there's a kind of proper time to adequately consider the back, which is obviously on the agenda as part of the quarterly to review. But in all, it was a pretty robust but really helpful set of conversations.
Thank you. Any questions for the Chair of Audit? No? Then we'll move on to Karen. Karen Deeney, please, Finance and Performance Committee. Anything to escalate to the board?
Thank you. Thanks, Chair. No, essentially, the report can be taken as read. Just to highlight that with regard to the second alert, just to highlight that the Finance and Performance Committee remains very focused on assurance regarding care group delivery, particularly against their cost improvement plans. So that's a monthly focus. With regard to the third alert about deferring a decision to approve a business case, just to highlight that since then, some very focused and prompt work on that paper is underway, and it will come back next month with the required detail. And then perhaps with the assurance in mind, we just wanted to highlight that the committee, we received an overview of new finance metrics, a new scoring mechanism for application within the performance and accountability framework. It's a weighted system of metrics applied systematically to all of the care groups, and identifying a 6-point scoring mechanism from outstanding through to requiring intensive support. The committee really welcomed it. It's really helpful, helps us understand the level of focus and support required, and really supports triangulation. And there were recommendations within the committee that consideration is given to whether that approach could have more wide application against other metrics, and we'll be taking a proposal next month to look to progress that. And no, that's a summary and update from F&P.
Karen, look around, colleagues. Any questions to the chair? No. I'll move on then to the quality committee. You, please.
Thank you, Chair. There are 2 reports here. The first one from the 25th of September, I took the board through the salient issues at the October board, which is just the formal report. The report from the 23rd of October, just a couple of things to note there. We received a report from the Clinical Services Care Group, which highlighted issues regarding capital equipment, replacement for aging equipment. And Scott highlighted, of course, this wasn't an issue just for this care group, but there were 2 areas where this could impact on registration and sort of licensing. The one, the impact on breast screening services, and then the nuclear medicine services, the latter that received a license renewal for only 2 years rather than the usual 5 due to the age of equipment. So we thought that was important, that the board should be aware of that. Just to confirm, because I think we are required to confirm this, that we received a progress report on, well, the review of safe staffing related to quality that I mentioned before in nursing. We receive a monthly report, but we actually this week received a 6-monthly conglomeration of that, and that was much more useful to see over the last 6 months whether there had been any impact on quality vis-a-vis any staffing issues in nursing, and that hadn't. And finally, I think this relates to the next paper that we're about to receive after copy. We considered the progress report for the Q2 period against the Trust's strategic priorities. And when considering that the Quality Committee felt that we could actually, within this report, generally consider the issue of it could be even better if, and talking to Suzanne Hargreaves after the meeting, she said that previously that used to be considered, but not just how well we were doing against the price, but those areas that we were actually having some challenge with, and this report, I think, thinking going forward from wanting to move from SOC 3 to SOC 2, that sort of rigor, and I think would be really useful. And in particular, the objective of having the right people in the right place with the right skills. The assurance metric that we were using, that was the safer staffing report, which really just all they confirmed to us really that we have enough people, and that we're meeting our establishment, and that they don't really tell us that those people have the right skills or they're in the right place at the right time. So some thought be given to how we get real assurance, get something, and I think it's a very, very difficult area to get assurance about, because it's more detailed than just an appraisal report and such. It's how you get underneath some of that data, and so we raised that as an issue, and that may well be picked up after talking in that, so that's all I wanted to say.
But for the minutes, Nicola, if we could have the last 2 items of Hugh's report as chair of the quality in. Just put them in that they're in relation to item 129. Yeah. So that we're clear when we read the minutes the next time. Is that okay?
Yeah, that's fine. Thank you.
Any questions for Chair of Quality? No. Thank you. Thank you to all the chairs. Then we accept the report. We note them. And before we break for a 10-minute cup of tea and comfort break, let's just check with colleagues. Some of you have got coats on. The impression that several of you are cold.
Yeah.
Some of you are not. We shall follow the principle of those who need the most. So take into effect the aging process, etc. Some of you will need to be warned, so I look to the company secretary to just the heat. Great colleagues. 11:10. 11:12.